Good afternoon, everyone. We are going to have a very interesting facilitated discussion through Q&A with some of the wonderful practitioners who have been leading practice on asthma in home interventions. And I'm going to let them open up and give a few words about who they are and what they're doing. And we're going to hear from Felesia Bowen, Theresa Soriano, and Ray Lopez. And Ray, why don't we start with you?
Sure. Hi, everybody. Thanks for hanging on. Getting through the day. So I'm a community health worker. I have been since 2001. I'm still currently a practicing community health worker. I haven't let go of my caseload completely. I lead a team of community health workers who are doing these in-home asthma interventions. Our unique feature is that we actually roll up our sleeves and perform the in-home interventions. So we do the IPM work ourselves. We perform interim controls. We started our program because our visiting nurses saw the need for a community health worker to really focus on the home environment. And we didn't have really a program model to begin with. I guess you could say our program model was to sit with the family, figure out their current situation, understand how asthma was affecting them, look at the home environment, and then collaboratively come up with a service plan and basically just do what it takes, do whatever it is that no one else is doing. And so that's why we sort of do it all, and we're experts in this field because we just started to do it, and we've done it more than 1,000 times.
And doing it really well in East Harlem. So thanks, Ray. Dr. Soriano.
Hi, everyone. Thank you for having me. I feel like a little bit out of my league here because I'm really sitting with the experts doing this in-home asthma work. My background is in adult primary care, doing home-based primary care for homebound, mostly elderly adults in East Harlem and Harlem. A Mount Sinai-based program called the Visiting Doctors Program, in which I continue to see patients. And over the 10 plus years that I have continued to be involved in the clinical work, but also in the leadership component, I experienced firsthand the difficulty in, just as everyone's been talking about today, how do you justify the high touch, low volume, slow medicine type of work in a large health system in which fee-for-service is still king, and having to work within a system to grow and triple the size of our program took a lot of trial and error, a lot of learning what finance people understood about clinical care, which is not much, and so therefore how do you speak the language of what they understand. And over the last couple of years, I've taken a lot of that work, and also an understanding that although I'm a physician and I worked on an interdisciplinary team seeing patients in the community, we realized the importance of community partnerships. I take care of patients with asthma and see their families who sometimes also experience the complications of asthma, often influenced by their environment, and I don't have the training and knowledge, nor does my interdisciplinary team within our healthcare system to really address those factors that make the most long-term difference. So again, my last couple of years have changed what I do in trying to champion these types of partnerships within the community, and also starting to do that as a health system with payers, and sort of taking those three parts and creating a good love triangle, if possible, so that we can really form these meaningful partnerships that make everyone's work sustainable in their own way. Everyone's has a different perspective on this, and I'm learning to learn everyone's perspectives, and so I've been involved in our district work, leading the PPS here for Mount Sinai, and also learning how we can weave together a lot of these multiple parts to make the changes we all want to make in different ways.
Thank you. And now we'll hear from Dr. Bowen.
So thank you very much for having me. I want to say thank you to Ms. Linda Whitfield-Spinner from the New Jersey Primary Care Association for facilitating my invitation. I appreciate it. I'm a pediatric nurse practitioner, and I still practice, and I'm an assistant professor at Rutgers School of Nursing. So the project that I have is a research project that's funded by Robert Wood Johnson Foundation and is part of a Nurse Faculty Scholars Program. I'm working with Jewish Renaissance Medical Center, and we are bringing asthma care, specialty care into the community, realizing that for some patients, they will benefit from home care, but that can be very expensive. So we want to figure out which patients will benefit. So someone was talking about having providers be able to write a prescription. We'd like to be able to do that, but the feasibility in a federally qualified healthcare center of doing this is really tight in terms of resources. So we have 3 arms. It's a group of children who are getting usual care, and the other 2 groups get this asthma specialty care where the nurse practitioner, who's me, goes into the clinic, and it's basically after hours and weekends, which our low-income parents really appreciate because a lot of them don't have jobs where they have paid time off, so they miss pay when they have to take their children for asthma follow-up care. So we're bringing this to them, monitoring spirometry, managing the medications, and then that group is randomized, and part of them get a home visit where we go into the home and we use the pediatric environmental home assessment checklist to help them identify triggers in the home. And unfortunately, this is a small study, so we don't have the money to go in and do IPM or fix roofs and things, but we do help them facilitate help within the community. So in the city of Newark, we have our public health department that has a mold remediation program. They do have funds to do some restorative care if there's holes that rats and mice are getting through, so we can make those type of referrals for them. We're hoping to demonstrate the efficacy of this and that the children are getting better. Some of the outcome measures are decreased ED visits, parents not having to take off and miss work, decreased hospitalizations, and we'll be able to cost this out and hopefully get the federally qualified healthcare center to say, yes, we want to invest in this, make some policy changes, and be able to advocate or, the insurers to help.
So thank you. So let's get some perspective on what has been the single largest barrier to success in you all implementing a sustained and a consistent asthma in-home intervention.
Well, I would say cost and buy-in. I mean, when I speak to people, especially within the healthcare center, and it's small, it's not like, a big Mount Sinai. This is a federally qualified healthcare center that's operating on limited dollars and grants. They understand that this is a good thing and we should be doing it, but how much are they going to spend on this population? So that's the really difficult part. So with this project, we're hoping to demonstrate that there is a big benefit in the end. But that's going to be at the cost in the dollars, the sustainability. Everybody wants to know up front, we're talking about return on investment, what's it going to be? And it's difficult to explain that we have the 6 or 7-year-old right now with very severe asthma. They're not well controlled. The environment that they're living in is impacting this, and if we don't do something about it, that there's a probability that when this child grows up to become an adult, they could have COPD. Well, that's 40 years down the road. I want my money returned right now. You know, I don't care about 40 years down the road. So that's the difficult part. from
And
my perspective.
have you been able to quantify the lost school days, the lost work days, the hospitalizations that would not occur if your intervention was successful and went forward?
Well, that's one of the things that we're monitoring. So it's kind of before and after, you know, what was the average lost days by the parent and the child before coming into this intervention, and then while they're in it, which it's a 12-month program. So while they're in the program, we will be measuring lost school days, lost days of work. And the lost days of work for parents could be because their child's at home sick, because a lot of times in our communities, the children aren't at home. We have problems with presenteeism instead of absenteeism. So they go to school, but they're too sick to learn. They're hanging out in the nurse's office because mom has to get to work, so she sends the child to school. And then also the days that they're not missing because, you know, they're at home with their children or taking them to the provider's office. So we're trying to capture that information, but it's hard. You know, people want hard and fast dollars and cents.
That's right.
From a health system perspective, I think I agree. It often boils down to cost. I mean, even a big health system like Mount Sinai, but also an FQHC needs to know that what they're investing in will, in unfortunately very short term, yield them as much money, if not more, back. And I think that's where the partnership with payers can really come in, and this is when now everything's sort of aligning, thank goodness, in what's largely still a fee-for-service payment structure, where in our system, what will get approved is something that is billable. We can send a bill to whatever plan or payer, and that will be our return on investment for whatever that is. So of course, that always veers towards a provider, a medical service. Even if these in-home asthma interventions may be billable, with other interventions we see in the health system, they're often actually not reimbursed, even though they're billable. So what you get back, even if and people are learning that, so that is often a barrier. But now that our system is pretty aggressively moving towards going into fee-for-value contracts or shared savings or some version of taking risk on our patients, being accountable for our patients, these kinds of programs change. They cost a lot at first, but you can see, and in the case of my home-based primary care program, visiting doctors, there's data from our program as well as out there in the nation that home-based primary care, after 1 or 2 years of that upfront investment, reduces hospital admissions, unnecessary emergency room visits by up to 20 to 40% in a Medicare, mostly Medicare population. It reduces institutionalization rates, such as nursing home placements, by up to 20 to 40%, depending on the study. So there's evidence out there. It just costs a lot to put into place. And so, however, if you're responsible for the cost of care for that patient, what you hear now and what I'm learning a little bit more to do is to put it into that, what is the cost that we're saving and how is that the return on investment, which is what everyone wants to be doing. We want to be preventative. We don't want, right now, the patient coming to the hospital, being admitted for 5 days is your revenue. And in the new model that we're all hopefully moving towards, it's saving them from being in the hospital or the emergency room. That will actually make you money as a health system and a payer. It's just now that we're sort of all talking to each other, it helps, and it also helps with thinking about sustainability as a community-based organization or program where you're doing such important preventative work that really addresses the roots of the problem in many cases, much more so than the medications are.
Thank you. Biggest obstacle?
Agree. It's funding is always the issue. I've been really lucky at the organization that I work for because we've operated on the soft money, on grants. And, you know, my organization, Little Sisters, has made a commitment that if we were in between grants, that I wouldn't lose my job. And, you know, most community health workers, most community health worker programs, that's in fact what happens. You know, someone will receive a grant for a few years, they'll employ community health workers, and once it's over, there's no more work. So that's enabled us to at least have a program that's run continuously since 1997, but we've still just had to operate on very bare bones, really just trying to use all the funding to get as many community health workers out there and helping as many families as possible. And you know, we could use a little bit more funding for some office infrastructure, for, you know, implementing mobile devices to capture data, having better and faster ways of analyzing our data. We've built that slowly and gradually, but you know, that sort of financial pressure also affects our ability to hire and retain community health workers too, because they, you know, we may get someone inexperienced who has those qualities that we need, but after a few years, they're on to the next opportunity, and then we're left sort of starting back from scratch, you know, finding someone who we can hire and train up. So, you know, I've been at this for about 15 years, and you know, there's still a lot of kinks to work out, but I think we're ready to at least try our model, try multiple models, replicate, expand, whatever it is, just get to see if we can get an infusion and try some more and help the people in need.
So how have some of these obstacles really impacted the families you're serving? Do you have any stories about some of the families you're working with?
Well, there's so many.
I'm sure.
Yeah, I mean, there's one in particular who just came to mind, who lives in public housing. Someone who's, you know, single parent, works full time, has multiple issues in her home, but you know, made complaints to the housing provider, but since she works full time, she just couldn't get anyone to go into the home because she couldn't take the time off from work. So we had to figure out a way to get the housing providers to come in on days where the parent could be home. And we invested more time with this family during vacation times, and she worked at a school, so we had to modify our intervention to do as much as we can over the summer because we knew it would just be hard to see her during the school year. She's, I think her kids are all grown up now, and I think have less issues with asthma now, but still has the housing problems that we seem to resolve, but then 6 months later, 12 months later, it's back. And so we're still in touch with this family. It's sort of a never-ending saga dealing with all of these structural conditions in the buildings. But it's someone who's picked up a lot from us. It has inspired us to keep doing the work.
So are we talking about mold conditions or pests or?
Yeah, all of the above, yeah. The pest conditions, excessive leaks and moisture and mold growth in multiple rooms.
Yes. Just last night, I was at the clinic collecting data, and so for me, collecting data is providing care. And there was a mom who came in. She's a single mother with her child, and she'd stopped giving her son his asthma medicine because he's better. He doesn't need it anymore. And I know I was supposed to come and follow up with you a couple of weeks ago, but I couldn't because I couldn't take off work. So I'm glad you're here on this Thursday night. So, you know, my child doesn't have to miss school. I don't have to take off work. And so it was an opportunity to educate her after we did the spirometry and really did an in-depth history with her son, who was still having problems with exercise in gym class. And to be able to teach her that even though he looks okay, he's not blue, he's not coughing, but look at his lung function. You know, it's low. He's in the yellow zone. What does that mean? So she was so appreciative when she left, and I was drawing on a napkin that came out of the roller, and she said, I'm going to take this with me because this will help me remember when I'm going to give the medications. And that was just so humbling for me to be in this FQHC after hours. It was just a few of us there, and to have that mom say that and to want to take this piece of napkin that I had drawn on. And you know, for people who know me, they'd probably be slinking in the chairs right now because I have to say that this is a huge social justice issue. And, you know, it's the white elephant in the room. We can't get around it. The kids that are most affected and dying are the ones that are most marginalized, the blacks and Latinos, the poor kids. You know, I think if it were a bunch of little white kids that were dying at 4 times more than everybody else, we would have a whole bunch of policies in place to fix this. And if it were happening in the suburban communities and in the really nice homes, we'd have a ton of money thrown at this to fix it. But you know, these are the poor kids, and you know, they ought to just be happy that they have a place to live, that we put them in this social housing that we have. And it's environmental racism, you know, with the rats and the roaches and the deplorable conditions that are going on around it. You know, the people who are making the policies, I challenge them to come and spend one night in one of these apartments with a family. And it's not because they're poor and they're nasty, it's because this is where the roaches live, that there's 100 and some families throwing their garbage out and the rats are gonna come and cluster there. You know, this is where they're sequestered to, and because their children are sick and they're missing enormous amounts of school, they don't learn. If they are in class, it's presenteeism. They're not able, and this cycle of poverty continues to perpetuate itself, and these children are not able to get out of these situations they're in because they don't have the education, and they don't have the education because they're sick, you know. And I'm sorry if I'm getting all riled up, but this is. A passion of mine. I've never taken care of more children who've died from asthma than before going to Newark, New Jersey. And guess what? Every kid that died from asthma was a poor black child. And their parents worked, and they did the best that they could. We gave them the best medicines. Some of these kids are maxed out on inhaled steroids because they go home and they're living in basement apartments with mold, you know, everywhere. Their zip code is killing them. And many of my patients don't have a voice because they're not citizens. You know, they're afraid of getting tossed out, so I just better be happy with where I am and what I have, and I don't want to make a big wave because the landlord's going to report me. And we have to stand up and do something. And, you know, I say to my bean counters all the time, that's what I call lovingly my finance people, you know, we have to have a heart in this. These are children, and these children are going to go up to be adults, and these are the same folks that we're going to be looking at saying, why are they on disability? Because they have COPD? I have children right now that fit the diagnostic description or criteria for COPD. 12-year-olds that no longer reverse, you know? Their lungs won't reverse anymore. They're so sick. So those are some of the barriers that I see, you know. And I feel like I'm preaching to the choir because you guys care and you're here.
So we've heard the bad picture here. So what are the opportunities? Because you're clearly very optimistic as well. And what are the opportunities to address some of these barriers? Any of you?
hard to follow, Dr. Bowen. I couldn't agree more. I'm an adult practitioner, but yes, it all starts with the kids. And there's, I think it's part of the mess we've created as a healthcare society that we prioritize what pays the bills for whoever the organization is. And or we go to where the cost is first, which is the adults, but it's because of the lack of foresight and prevention and care in the beginning. And also, in hearing the work of your programs, it brings to bear the importance of this holistic and multi-component, although it's important to study each individual component and what that brings to the outcome. I think in many chronic diseases and chronic conditions, you have to take a look at all sides of it. It's not just the medical or the environmental or the social or the educational or the parents. It's everyone. It's the educational system. It's understanding how health literacy plays a part in this, or just the understanding of what a chronic illness is, health beliefs and the culture. And so as we break it down into their component parts and which is most important and which has the biggest bang for your buck, I think at the heart I tend to agree that you just, you can't always break it down into each individual part, because the sum is greater, or the whole is greater than the sum of its parts. And it's that time, and it's taking into account that particular patient or family and what cluster of things they need that we call now a care plan, but it's really taking the time and the effort to communicate amongst all the people that touch that patient or person or family or community that will really answer a lot of these questions. But opportunity to answer your question, I think lies in events like this, raising awareness and bringing people together who are doing similar work from different vantage points. I feel like a foreigner in an amazing land, but representing Mount Sinai Health System, there is this new, more official acknowledgement of how important looking at programs like this are as part of the health system, not just something that happens outside, but rather how do we pull this together and help support each other in our common missions. I don't think the bean counters want to do the wrong thing or don't want to support it. It's just everyone at the end of the day has to do their particular job. And I think if we can all learn to speak each other's language and learn how we can work together to make things, and I count the community partners, big health systems, small health systems, which have different needs than larger health systems and have different priorities, but also the payers. And the payers, I think, are crucial here because they're the ones that define the sustainability for us right now, at least. And the more we can get in touch with each other, I think that's where the opportunity really lies, partnering on projects in which all three parts are involved and not just, a side part of it.
Yeah, I agree that I think there are more opportunities now than ever before, which I'm optimistic for. I think I've met people here that I want to begin discussing different ideas. We're also, the past year and a half, our organization has been looking at DISRIP, and we've been struggling to keep up and decipher all this stuff. We haven't had anyone sort of solely dedicated in our organization to keep track of this, so it's been hard for our organization and other CBOs. Finally, I think we've spread out the load and are just waiting to see what comes down the line. We're excited on that front. We're also have a long relationship with Mount Sinai, so we've started to talk to the health homes we're sort of starting from there. You know, a lot of the work that we do doesn't just work with individuals. You know, we do spend a lot of time and effort on looking at systems, systems change. So I know that these immediate opportunities are going to be in tension with our time and wanting to sort of work on policy change. So, you know, from our vantage point, we have to sort of balance all of those things. You know, find a new revenue source here and there, but also sort of keep fidelity to our mission, our values, and sort of the program model that we've developed.
Well, Dr. Soriano, you mentioned that it's an important opportunity to have the three key stakeholders. Are there others who need to be at this table? And maybe all of you could think about that.
The patients and the families and communities we serve, I think, are very important here, where oftentimes the most successful programs are helped to be shaped by the people that the programs are serving, and I think that's something that shouldn't be forgotten. We, in Disrupt, in the work I'm doing and helping a very large team actually do, they are working and spending a lot of time talking to community members, trying to see what the current perception is of a large system like Mount Sinai, how they would like to see all the different services they may be experiencing currently work together better, because I think what is true is that there are actually a lot of services out there. We don't know which are quote unquote better than others, because they're all very different. They're run differently, sponsored by different organizations, and I think the challenge here is to take the patient's or the person's perception of what works well, what doesn't work well, how they want all the people involved in their care talking to each other. It might be very different, and actually we're learning it sort of is different from what we think is the right way to take care of a person. So I mean, I think at the heart, there are many stakeholders, faith-based organizations as well. They're often the keystone in many communities where messages coming through a pastor or a religious leader make all the difference in the world, as opposed to their doctor or even their family members. So, you know, we're learning as we go, learning from our mistakes in the past and our shortfalls, and trying to really embrace what Disrupt is supposed to stand for. But you know, it's a challenge for everyone. I think we're very mindful of the fact that smaller organizations and even pretty large ones cannot keep up. We can barely keep up. Actually, we can't keep up with the Disrupt changes and the policy and the need for information, and really feel for organizations that are in multiple Disrupt PPSs, because the messages and the messaging is conflicting at times, and it's coming from all angles. So we are trying to work on communication that is simple as possible, as upfront as possible, with some warnings and ability to get people involved in a way they can be, and without forcing them to get involved in a way they can't. But again, there are challenges because of all the pressures and wanting to, I think, please too many people, that you don't want to do that either.
I take kind of like a stone soup approach, you know, Pete's person, so I like that story. But the patients that we serve with whatever condition certainly need to be at the table, and we need to hear what healthcare means to them. As providers, we have an idea of what it's supposed to be, but what does it mean to that family or to that community? And what does access mean? You know, access means that we have in this wonderful, you know, healthcare facility, world-renowned pulmonologists and allergists, and they're here from 9 in the morning until 4 in the evening, but that's when everybody's at work, okay? So, you know, access means giving people what they need at a way, you know, in a way that they can get it. I also think bringing the community, definitely getting out of our silos and walking through the streets and seeing who else is out there. Because there may be CBOs that are doing work, and they have a limited pot, but 2 + 2 = 4. And we can put our resources together and go really far. So an example is that in the city of Newark, the public health department came and said, we have some money and we're supposed to be doing some home renovations for this group of people, but we can't really identify them. And I said, well, I got a project and I can identify the people, so let me send them to you. And it's just been this back and forth give and take. So that's just one example. But and again, having opportunities like this, I'm so happy that we can get together, and the networking opportunities and what are you doing, and maybe we can work together, and having a sense of humility. My name doesn't always have to be out front, and I don't always have to be the one that holds the purse strings when the money comes in, but let me contribute and be fair and be transparent, and it's kind of like a code. Whoever is the most skilled at the time, for whatever the reason, for whatever the issue is, let them take charge. And that sometimes that means that the big names and the big boys have to take a step back, So those are just some ways, I think. I'm very optimistic, or I wouldn't still be doing this after so many years. But every day, if there's, not 9 people, but only 8 people, hopefully there's no people who die because of asthma.
Well, this has been a great discussion and a great day. Could you all just give me a minute summation of what do you take home? What's your message that you take home today from this entire day?
My take home is that it is an important issue. It doesn't always get a lot of play on the television or whatever, but it is, and there's a lot of people, very bright and talented people who care about asthma, and so I'm energized just from being here. Thank you.
I think let's just break out of our silos. I think sometimes I've heard some presentations today that I learned a lot from, and I still feel like there's people that speak different languages than, different dialects than I do, and we just need to become more comfortable talking about this, from all the different angles, and maybe the next summit will lock the doors and try and hammer out some agreements.
I see. That sounds like an opportunity. And Dr. Soriano?
I agree with everyone on the panel. I learned a lot about all of the different work out there, and I think for me this just confirms the importance of bringing multiple stakeholders who surround one particular condition, in this case asthma, but from birth through adulthood and older ages, it's very much the same theme. So if we can continue to convene things like this, not just for asthma, although this is very important, and especially in the community we serve at Mount Sinai, it's a huge public health issue. We'll make a lot of progress, and we will learn how to understand each other a little bit better, and where the collaborations really can be, even for organizations that maybe should be competing. There's so much work to go around that we can all lend something and learn from each other and make ourselves better too. So I think if you take that with you in whatever work you do, that would be my take home.
Well, thank you. Let's thank our great panel today.